All right. Good morning, everybody. Good to see some familiar faces and some new faces. Now, most importantly, where can I put my coffee, right? That it won't spill. So I'll figure that out. I get to talk today or this morning about sort of an overview of MS. The big picture, so to speak. Some people say, okay, what's the landscape? What's the current landscape of MS? I also get to be the one that reminds you where you're at. Okay, so those of you in the auditorium, you should know where you're at. If you've forgotten where you're at, have another cup of coffee and it'll come back to you, okay? But those of you who are joining us from all over the country, we're in the South. So when you hear me talk, you know you're listening to somebody in the South, okay? So that's also part of my job, I think, with Can Do. My Can Do friends always, they're a little jealous of my Southern accent. So when they come to town, they tend to practice it a lot. And, you know, and I just humor them, you know. I understand. Not everybody can speak Southern, right? Okay, where are we going here? There we go. All right, so our learning objective this morning, we want to understand some basic facts about MS. We're not digging deep, we're just looking at the basic facts and things that you need to know moving forward. We want you to become familiar with all the members of the healthcare team that might benefit you in the future. We also want to bring in the important aspects of health and wellness and how that can help you navigate through your journey with MS. I'm having mouse issues here, sorry. So what is MS? MS is actually the most common chronic illness that affects the central nervous system in young adults. So it's a lot more common than people realize. It's an immune-mediated disease. Inflammatory disease that is really, we're not sure what all contributes to someone coming down with MS. We've learned a lot more about it. Who gets MS? This slide kind of demonstrates that it doesn't just affect a certain population of people. We have pediatric MS. We have MS in just about every ethnic population in the world now. There are a few remote groups that we haven't verified, but mostly everybody. But it is more common in certain groups. More women get it than men, generally speaking. It's more common in people of Northern European ancestry. I like to say it's all the Vikings' faults. You know, they brought it all down to the rest of us when they were raiding and pillaging. And it commonly is diagnosed between the ages of 20 and 50. But there are people, obviously, that are diagnosed much younger. Some people are diagnosed much later. So it can happen in those populations as well. So what do we think happens? Well, you've all heard of the genetic component of MS. We've identified a genetic component. Now, what that means, it's not a genetic disease in that if you have MS, you're going to pass it down to your kids, okay? Not that type of genetic disease. What we found is that people can pass on the genetic susceptibility to the disease, okay? So I may have a genetic susceptibility to MS, but I didn't get MS. What we think happens is you have these people who are susceptible to MS, and then they encounter certain things at certain times in their lifetime that create the environment for the disease to develop. We think infectious agents are a big part of that. We've identified some viruses and some bacteria and infections that we think may be triggers. Also, there's some environmental factors that we think play a part as well. And so when all those things come together, then you get the abnormal immune response that develops into MS. Okay? So this is some of those factors that may contribute. And I'm going to slip my glasses off because I got to see the fine print here. So genetically, females, we talked about that. Female sex tends to have more MS. If you have a family history, you may be more susceptible to MS. If you're of Northern European ancestry, that increases your risk. Then the external factors, we talked about the bacteria and viruses that may be a part, environmental factors like low vitamin D. That's one of the things we've learned in recent years, that people with low levels of vitamin D are more susceptible to MS and then don't do as well after they're diagnosed if we don't get their vitamin D levels up. And that also, we know that there's more MS further from the equator. So there's less sunlight, less exposure to sunlight. However, I think also in our modern times, we don't get out in the sun as much. We wear a lot of sunscreen. So we find people even in sunny climates that have low vitamin D. So we recommend everyone get their vitamin D levels tested. We think there are some dietary things that may contribute, and that's where a lot of research is being done as well. We know cigarette smoking and in some cases some forms of pollution may also increase risk. Now, I put this slide up just to say it's the immune system, and it's very complicated. There are a lot of players. You know, we used to, when I started in MS, which was longer than I'll admit today, you know, we focus mostly on T cells. Oh, it's those T cells. And as we've learned more and more about the immune system, we realize that there are a lot more players in this disease than just T cells. So that's all we're going to say about that, right? So here we have a polling question. And I want to know how many of you know what type of MS you were diagnosed with? Raise your hand if you were diagnosed with relapsing remitting MS. Okay. That is the most common diagnosis that people are given. What about secondary progressive MS? Anybody? Okay. What about primary progressive MS? Okay. All right. The last one, progressive relapsing MS. Okay, one person. All right. So these are the traditional categories that we've described MS. What you need to know about these categories is they were developed from the natural history of MS. And what I mean is, before MS was treated, before we had MRIs, before we had a lot of the technology that has helped us further describe the disease. So we've actually revised recently our categories, and I'm going to talk about some of the new ways of categorizing or looking at MS. But it's important to remember that, you know, if you have cancer, for instance, most cancers they're going to look at and they're going to be able to say this is a, you know, X sensitive, B whatever, stage whatever cancer, right? With MS, these categories are descriptive terms. And so sometimes they don't fit entirely correctly, or sometimes it may take time to tell which category fits you the best. There's not a lab test that tells us, oh, you're relapsing remitting. There are a lot of factors that go into that. And so sometimes people get frustrated by that, understandably so. So now that we have greater technology, more ways of evaluating MS, these are how we're moving forward, how we're describing and categorizing MS. Clinically isolated syndrome, relapsing remitting MS, secondary progressive MS, and primary progressive MS. So clinically isolated syndrome. To make a clinical diagnosis of MS, you need to have 2 neurological events, okay? It's part of the criteria. Well, now that we have MRI, Many times we can see that somebody has lesions that look just like MS when they have their first event, right? So take, for instance, optic neuritis. That's a common occurrence. Somebody has a bout of optic neuritis. That person may go on to have another neurological event and have MS. Or they may just have optic neuritis. It doesn't have to be connected to MS. Now we can do an MRI, look at the MRI and say, okay, you've had optic neuritis and we see these changes on your MRI that look very much like MS. So we feel like this is your first event with MS. So your diagnosis would be clinically isolated syndrome. Now, why is that important? Because we've learned that the earlier we treat MS, the much better outcome people have. So many times your provider, even if you haven't gone on to have that second neurological event, may recommend that you go ahead and treat at clinically isolated syndrome stage so that we can keep you in that stage longer and prevent some of the advancement of the disease. Okay, in the South we have a saying that horse is done out the barn, meaning we want to keep your MS, your horse, in the barn where we can control it. We don't want to let it get out of the barn, right? So the earlier we treat, the better off. Then relapsing remitting MS, secondary progressive MS. Relapsing remitting is an initial stage that can move into secondary progressive. So those two are kind of a spectrum. Now, some people never actually move into secondary progressive. So we're able to hold them, in the beginning of the spectrum. Primary progressive MS we found is really sort of a different animal. We thought it was just a presentation of the same sort of disease, but primary progressive MS has its own characteristics and differences now that we've been able to identify. So we have these four categories. Then we go through one more question. With relapsing forms of MS, do you have activity or do you not have activity? And by activity, we mean relapses, MRI, new lesions or active lesions on MRI, or some sort of worsening of your disease process. So we would consider that with activity. And the goal is to get you to the without activity, right? So progressive forms, same thing. Are you progressive? Do you have progression? Or have we been able to stabilize you and keep you from having that progression? So that's the newer way that we categorize MS. So what does MS cause? Well, MS affects the myelin and the nerve fiber in the central nervous system. The central nervous system is kind of like a motherboard in a computer, right? And I'm going to sound really smart here, but I have no idea about this kind of stuff. But I did read about motherboards. And motherboards are kind of the way the computer, different parts of the computer communicates to each other. And so that's kind of like the central nervous system. The central nervous system carries messages from the brain down the spinal cord to the different parts of the body to tell it to do certain things, okay? So MS interrupts those nerve fibers and the myelin that insulates those nerve fibers. So messages can either not get there at all or get there longer, slower, or in a different way. So it just really messes up the communication. And I think that's why you see so many different potential symptoms with MS. So this is a picture of a demyelinated, healthy nerve fiber and a demyelinated nerve fiber. So you can see the top, it looks like a string of skinny sausages, right? And so those nerve fibers, the orange arrows above is the impulse, okay, or the message. And so you can see it goes smoothly. The transmission down that nerve fiber goes easily and quickly. The lower picture is the conduction in a demyelinated nerve fiber. So you've got these gaps that the message has to literally jump across. Or it sputters across, doesn't get completely there all the time. So that's what happens with MS. So how do we manage MS? Okay. Management roughly falls into 3 areas. Okay. We treat relapses. If you have relapses, we treat them. We manage the symptoms. Symptom management is a big part of helping people maintain great quality of life, managing those symptoms, minimizing them the best we can, and then we alter the course of the disease. So sometimes it's easy to confuse one area into the other, and we'll talk some more about that. So when we talk about altering your course of the disease, what do we mean? Well, we have goals for that. And our goals are, number one, we want to choose a drug that you can tolerate. If you can't tolerate the drug, then you're not going to take it, and then, it's not worth taking, or trying. We want the drug to prevent relapses. If you have relapses, we're not able to eliminate all relapses in most people, but when you have a relapse, we want that relapse to be milder. We want it to respond to treatment, resolve quickly, and not leave you with any residual symptoms. Okay? We want your medication to prevent accumulation of disability. We want you to be able to function in roughly the same way a year from now as you are able to today, or better. We want your MRI to be stable. We don't want any new MRI lesions. We don't want any lesions becoming active or getting larger. And we want your other MRI parameters to be stable. And ultimately, we want all this to happen so we can improve your quality of life. And an effective therapy given early in the disease course can really address all of these goals. So, okay. So when I first started with MS, we had very few treatments. And so we tolerated a lot more disease activity because we didn't have that many drugs to switch to. And some of the drugs we had worked in very similar ways. Now we have a lot more treatments. And the beauty of those treatments is they all work differently, or most of them work differently. So if you take one medication that doesn't work, then another medication works differently and may work great for you. We still don't have all the information we need to be able to pick the right treatment for you ahead of time. We still kind of use the best information we have and help you make a choice that fits your lifestyle. But when you have more choices, that's a positive thing, but it can also be a stressful thing. And so a lot of folks are ending up with, okay, what therapy do I choose? There's a lot here, and which direction do I go? And I think it's important. That's where your medical professional, your medical team can help direct you. And hopefully they can communicate to you, okay, this is sort of what I would be thinking. These are my top recommendations for you. This is why. I don't really think these would work for you, or you can't take these for certain reasons. Help guide you through that process. Hopefully by the end of that decision-making process why you're on the drug that you're on and what you should look for and report, right? So, things to consider when you're deciding what medication to go on. Well, first of all, we want a drug that works, right? Efficacy. We want a drug that works the best possible that we can. But it also needs to be safe. And we're going to talk a lot about safety and efficacy and risk benefit. It also needs to be tolerable to you. Now, there are some folks who have side effects or problems tolerating certain medications. So, we need to be cognizant of that and help make the decision that you can tolerate. And also that fits in your lifestyle. There may be medications that you just can't be adherent to because of you travel all the time or whatever. We also need to look at cost. Cost is an issue. I think the good thing is a lot of our medications, the drug companies do have charity programs or copay assist, that sort of thing. And usually we can work on getting cost as low as possible for folks. So if you have been put on a medication and it is really costly for you, be sure you talk to your provider about that, and they may have a case manager they can direct you to, or the medication may have an assistance line that you can call and say, hey, what programs do you have to lower my copay? Because this is really financially hard for my family. The method and frequency of administration, and also how familiar is your provider with that drug. Sometimes providers, especially community providers that maybe don't see as much MS, may be reluctant to choose medications that are given by infusion or have specialty lab work. So that's where, as a MS center, sometimes we'll have a lot of referrals to us when they feel like things, like a person would really benefit from one of the specialty IV medicines. So when you're looking at efficacy and risk, benefit risk, everybody has their own sense of benefit risk kind of ratio, right? And benefit risk means different things. And I think as a provider, it's really important to give balanced information about that, right? We need to be honest and open and clear about the risks of medication. But we also need to be honest and clear and about the potential benefit. I had a great cartoon that I love to include here. That's a executive meeting. People are sitting around the table and they say, we've considered every possible risk except for the risk of not taking a risk. And I think that's important because when you're looking at MS medications, you also have to not just factor in the risk of the medicine, but the risk of not treating your MS as aggressively as you can. And now we didn't know who was going to respond, who might have more difficult courses of the disease. Now we know. So, well, we don't always know, but we know some factors to look at. So your provider may say, I really feel like you need to consider a higher efficacy drug because of these risk factors. So ask those questions, consider those things so you can make an educated decision that you're comfortable with. So, polling question. If you're on a therapy, how many of you are on A, injectable medications? Okay. How many are on B, oral medications? Okay, a few more. How many are on D, IV medications? Okay, even more. So that's been a shift in our treatment over the recent years too, is we're giving more and more medications via infusion, and they tend to be our higher efficacy drugs to some extent. But used to injectables were the standard of care, and now we have a lot more options and and people choose different options for different reasons. So the good news is they all can be effective. And, if you're taking an injectable therapy and you're doing fine, stay the course, But when we get through the different therapies, we'll talk about when should you reconsider your current disease-modifying therapy. So injectable therapies, we have interferons and non-interferons. So interferons work similarly. There are different, these are basically broken into low dose and high dose, and they're given different frequencies, but they're mostly given subcutaneous injection or IM injection. People give these to themselves at home. We teach them how to do that. Non-interferons, Copaxone and Glatopa, those are have a different mechanism of action. They're given subcutaneous injection at home, and most of them have an auto-inject like you see in this picture. Oral options, we have several, two of which are relatively new, and I believe we may have even an additional one that's not on this slide that was just possibly approved this week. But we have Gilenya, that's a once-a-day pill. Aubagio is a once-a-day pill. Tecfidera is a twice-a-day pill. Mayzent is sort of a newer version or a relative to Gilenya, and it's given once a day, but the dosing is different according to weight, and also there's some genetic studies and how people process medications that they look at. And then Mavenclad is actually given for 5 days twice a year. So very infrequent dosing. And then the next year, 5 days, 2 times. So it's a newer kind of schedule. Infusions, we have Tysabri, which is given IV once a month, usually. Ocrevus, which is given IV every 6 months, usually. There are some cases where those schedules may be changed slightly. Limtrada is given somewhat infrequently, so it's given IV for 5 days and then 3 days the next year. Novantrone is given every 3 months. I don't see much Novantrone anymore in the United States. They use it more in Europe, but there are some folks who still use Novantrone. So all that to say, it takes a village to treat your MS optimally. And yes, that pirate right there is Dr. Thrower. We all know and love him. He loves to dress up like Jack Sparrow. So that was one of our Halloween open houses. He loves Halloween. So, but it takes a village. And you've got to consider all of these things to have optimal treatment. You want to have a comprehensive team. You've got to take into account wellness and your other comorbidities and your other health issues. And your support system is going to be really important moving forward. Okay. I'm not going to read this slide, but I want to encourage you to look back at it. Comprehensive care is our standard. It is what we strive for. This is what we think best MS care is. And the important thing is you, as the MS patient, should be the center of that care, and you should have an active voice in making the decisions that happen in relation to your care. So hopefully you feel empowered by that to speak your mind and really ask questions and be informed. So multidisciplinary team approach. I apologize, our Y's over here, but I am biased, obviously, because I work in an MS center, but I feel like MS is treated best in a team approach. And working in a rehab hospital, we value that. We know the team is the way to go. 2 heads are better than 1, 10 heads even better. So with MS, you should look and see, do you have these team members available to you, or do you know how to access them if you get to the point where you need them? Many folks may see a community neurologist, not somebody that works in a center that has access to all these people, but in the same center, but they probably have those people in their community that they refer to that they know treat MS. So I'll let you look over those, but basically I want to point out the rehab team. We're going to talk a minute about what we're talking about with rehab team and primary care provider. A lot of folks come in and say, why do I even need a primary care provider? But you need different comorbidities, things like diabetes, hypertension, all those can affect your MS. So you really need to have a good relationship with your primary care doctor. And then when you start a medication, we want you to have realistic expectations. The disease-modifying therapy you're on is only going to work if you take it. They don't cure MS, but hopefully they slow it down or stop it. They don't eliminate your symptoms, and we're going to talk about that some more later in the other presentations. So when should you change course? Okay, if you're on a medication and you have a relapse, or you see that you're having ongoing progression of disability, if you're getting weak and you can't do certain things, if you see lesions, new lesions on MRI or active lesions on MRI, if you can't tolerate the drug and you're missing doses, or if you have safety concerns, lab work, liver function studies, or blood counts are going up or down, those are all things that we think about and consider whether or not it's time to change course. Now, you may have one of these things and it may not be quite time to change course yet, but it's like a yellow flag that we need to pay attention to. So quickly, what are we talking about when we talk about rehab? We're talking about physical therapy, occupational therapy, speech therapy. And does rehab help MS? And that answer is an emphatic yes, it does. You see reduction in impairment, reduction in disability, reduction in cost of care, improved quality of life, and increased ability to achieve goals. So we're big on our therapy around here. So we'll talk some about the physical therapy, occupational therapy, speech therapy, also exercise physiology, vocational rehab, recreational therapy, and counseling, all considered to be important parts of that. Okay, polling question. How many of you in the audience and in the virtual audience have worked with a rehab professional? Okay. Fair number of you in the audience have, and so I'm sure you know the benefit of that. And I would just say, if you are going to a rehab professional that is outside of your provider's office, ask them to schedule you with someone who is knowledgeable about MS. Okay, so are we running out of time? Close to? Okay, so I think Ann talked about this earlier, but Jimmy Hugo was really an important part of this change in thought. Exercise, when early on we thought exercise for patients with MS was bad. You should conserve your energy. Then we realized, okay, exercise isn't bad, it's okay. Now we realize that exercise isn't just good for MS, it's great for MS and helps almost everything. So hopefully you'll get that message today. Wellness activities, very important in MS, and an important way you can help control and manage your own disease. And we'll cover those as well. So, all right, any questions? Yay!
You may talk you may cover this in another topic, but I was just curious about myelin and the advances in repair of that myelin or myelination.
Yes, there's a lot of research going on in the area of remyelination and restoring nerve function, and a lot of things with stem cells. And there are actually different medications now that are being studied that hopefully will help restore that. There's nothing in the arena yet that we can actually use in a clinical practice. I think the research, though, is rapidly progressing. So I definitely think we'll see something in the next few years. I personally believe that health and wellness supports your body in a way it can heal itself to a certain degree. I think that really helps your body maximize its own healing potential. So that's something everybody can do now, but there's tons of research going on, absolutely.
What does it mean when you have new lesions but they're not active?
Okay, so that's a great question. So what does it mean when you have a new lesion but it's not active? So lesions, I think about, I'm an old wound care nurse, so I kind of think of it like a wound, all right? So you may have an area on your hand, a sore comes up, okay? And it's red and swollen and, you know, the blood's getting to it trying to heal it. That's inflamed. That's that's like an active lesion. So when a lesion is inflamed and it's actually the process of that inflammation is happening, it shows up on a certain view on MRI as active, or gadolinium enhancing is the term we use, because when there are active inflammation going on, it absorbs that dye and we can see it light up. Okay. Now, when that initial phase calms down and the wound actually heals, you may have scar tissue. You may be able to see it. It may be firm and not as flexible. That's a regular MS lesion. It's like a scarred area where there was this active process that has now resolved. Now, that lesion can come active again, or it can continue to get bigger, so we want to watch that closely as well. That answer? Yeah, okay, good.
Any other questions from our in-person audience here? Oh.
Is there any connection to MS and weight loss, or just not being able to hold your weight?
Well, there can be. It would fall under one of those categories of not a direct result of MS, but possibly an indirect. So sometimes, you know, in terms of your body being able to absorb nutrients and things like that, MS doesn't directly impair that. But there may be other things that are happening because of the MS that is affecting your ability to maintain your weight. You may have less mobility. You may have a decreased appetite. You may, you know, your GI system can be slowed down. So, you know, a lot of people have bowel and bladder issues with MS. So the absorption might be affected because of the motility being slowed down. So I do think that a lot of research is going on right now in terms of diet and MS, and I think there are definitely connections between the gut and the brain and the immune system that we don't fully understand, that we're just learning about. And so I think we'll know more, you know, why that might happen to some people moving forward.
What would cause old lesions to reactivate?
So old lesions can reactivate when the disease becomes active again. And, you know, sometimes it's just like you get a relapse out of the blue. You don't know why. So you might have an old lesion reactivate, and so you have a set of symptoms you've had before that now come back because the same lesion is inflamed again. So it's just a matter of inflammation occurring again in that one spot.
Okay, I think you might have answered this. Okay, so old lesions reactivating themselves, but then what were you saying? Something about the illness. I'm sorry, I haven't answered. My cough is right here. I need a little caffeine, but it was something about the. What am I trying to say? The illness. With new lesions in the brain also. So what causes the new lesions after years of MS to pop up again?
So new lesions or old lesions becoming active again, both of those would be caused by new disease process. Okay, so if we saw that, we would look at your disease modifying therapy and say, okay, is this really working as well as we want it to be? And maybe you've gone through a really stressful time, and we think that may be part of the problem. So we may leave you on the same, medication. But any new disease activity should be, paid attention to and considered. Okay?
Thank you.
All right.
I think we have time for one more in-person question, and then we're going to get to the questions from our virtual audience.
Still on the topic of lesions, if you're going from one MRI to the next, and it might have been my misunderstanding, but no new lesions had shown up, and I think they refer to it as your MRI, your current MRI was clean, which I thought meant that the old lesions possibly were gone. Do old lesions go away? Do they heal themselves, or are they always there?
Well, sometimes, but not usually. So if you think about it, you can have an area that's swollen and actively inflamed, so you see it on MRI, but it's small enough that when the inflammation goes away, it actually disappears. Now, there's still usually the process that's happening, it's just not visible. So it doesn't go away completely. It's still there. It's just not enough for us to see on MRI. Does that? Yeah.
Awesome. Okay, so we want to get to a couple questions that we got from our virtual audience. The first one is from Irene, and she asks if there is an upper or max age limit for taking DMTs.
So that's a great question. It's somewhat of a complicated one. So they used to say that, I used to hear physicians say, oh, you're at a certain age, your MS has burned out. So we don't think you are getting much benefit from your disease modifying therapy. I think that thought has changed a lot. And so we still think of whether you should be on a disease modifying therapy the same way in terms of, okay, what is it doing for your quality of life? Do you have any indications of ongoing disease process? Are there negatives to you taking the DMT? Is it, contributing to some other issues? So it's still an individualized decision that we make, not a blanket, when you reach age 60, you should go off your DMT. We've had patients at higher ages who have had active relapses. And if the old theory, applied, they would be too old to have active MS. So that decision is made on an individual basis usually.
Thanks, Tracy. And then, very good question, I think. If your MRI is not changing, but you still have fluctuating symptoms, what should you do?
Okay, so we're going to talk a lot about that today. So that's a great segue. So, but the point I want you to carry forward is disease modifying therapy is in that category of changing the course of the disease. Okay. Symptom management is a whole different category. And so MS is unique in the way that, you know, if you have back pain and you take a medication that treats back pain, your back pain goes away, hopefully. With MS, when you take a medication for MS, you still have the symptoms that MS caused along the way when you were developing it, right? So the disease modifying therapy corrects the underlying disease, but it doesn't treat the symptoms. Symptoms fluctuate apart from that a lot. Now, sometimes when people get on the right therapy, their symptoms do get better. But what I want people to understand is if you're continuing to have symptoms, that does not mean your disease modifying therapy is not working. It means we need to work on this symptom management area, and we have a lot of tools for that.
Excellent. Thank you, Tracy.
Thank you, Tracy.
Thanks.